Neuroscience Cafe. So the Neuroscience Cafe is offered to you by the Comprehensive Neuroscience Center. So the CNC, the Comprehensive Neuroscience Center, is a network of more than 500 UAB neuroscience persons. That includes faculty, clinician, staff, student, and trainee. So we span 32 UAB departments and 9 UAB schools. And we serve as a focal point for basic and applied neuroscience research at UAB. So this is really a nice place where we can get together and collaborate and exchange ideas about neuroscience. So the Neuroscience Cafe is a monthly community commitment designed to bring neuroscientists and clinicians together to discuss their current research. And we bring that, typically we bring that to local libraries. And of course, when the pandemic hit, we had to go virtual. So our mission is to accelerate the discovery of science by promoting excellence in basic, translational, and clinical neuroscience research, to promote education and clinical care through the integration of the UAB-wide neuroscience community. And we use that through mentorship services and community outreach. And our vision is a world
let me put it up there,
where the mysteries of the nervous system are solved. So just saying, this is our leadership. So I'm the director of the CNC. I'm Adrienne Lati. I'm a professor and a chair of the Department of Psychiatry and Behavioral Neurobiology. Dr. Lucas Pozo-Miller is also a professor, is the co-director of the CNC, and is in the Department of Neurobiology. And then Lawrence Insich is the associate director, is an associate professor in the Department of Optometry and Vision Science. So we are really excited today to bring a very important topic to the Neuroscience Cafe. This is not a neuroscience talk, but we thought that the CNC should do its share to promote vaccination, COVID vaccination. So we have Jeanne Marrazzo. She's a UAB professor, and she is the director of Division of Infectious Disease at UAB. She's internationally recognized for her research and education efforts in the field of sexually transmitted infection, especially as they affect women's health. You may recognize her face. She had been very visible during the COVID pandemic, and she has been discussing COVID on a lot of different platforms. And I remember several times driving home and listening to the radio, and Dr. Marrazzo was on.
Okay.
So Dr. Marrazzo received a medical training at Thomas Jefferson University in Philadelphia. She completed her internship and residency at Yale, a postdoctoral fellowship at the University of Washington, where she received a master's in public health in epidemiology. And then when she stayed as a researcher, clinician researcher, until she was recruited at UAB in 2016. Our second presenter is David Kimberlin. He's also a UAB professor and is the co-director of pediatric infectious disease. He's also the vice chair for clinical and translational research at UAB. His expertise is in the study of antiviral treatment for congenital viral infection. He is an advocate for vaccination. He provides medical perspective to parents who question the risk of vaccination, along with expertise in disease outbreaks. And he recently joined the group expert of the World Health Organization to consult on mother-to-child transmission to the SARS virus. So Dr. Kimberlin received his medical training at the University of Texas, UT Southwestern, where he completed his internship and residency and a postdoctoral fellowship. He joined UAB in 1994 to do another postdoctoral fellowship, and he has stayed there since then. So we are very lucky to have such expert people in the field of infectious disease. And just before we go and listen to the presentation, I will also speak about our next meetings. So next in May, we'll have Dr. Knight, David Knight and Amy Knight speaking about anxiety and stress following traumatic medical events. We will have in June, Dr. Newman from the University of Alabama in Tuscaloosa. And then we also have in July, topics of football and concussion and brain protection. August 19, Joseph Zaplarski, medicine and cannabis. And then we have October, exercise and nervous disorders. And finally, in November, we have another meeting with the University of Alabama. Can brain science help us understand how we should learn mathematics? So please ask questions. I think that probably Dr. Marrazzo and Kimberlin would prefer for the question to be at the end of the presentation. And their talk will be online. It will be on the CNC website and the NeuroCafe. So without further ado, I'm going to stop sharing and I'm going to introduce Dr. Marrazzo.
Great, thank you so much, Dr. Lotti. Can everyone hear me okay? Okay, great. I'm going to share my screen and we will go ahead and get started. So it's a real pleasure to be with you this evening, and especially to be speaking with Dr. Kimberlin, who's a really wonderful colleague and is going to give you a lot of really good information about the vaccines. So I have about maybe 7 or 8 slides. They're a little bit dense, but I'm going to try to walk you through them to make sure that you are able to understand, I think, and I'm sure you will be, some of the key points. And where we are now, I think, with the pandemic is actually in question. You can go to a state like Michigan and get completely freaked out. Or you could go to a state like Alabama where, things are pretty stable. We are sort of seeing some upticks in things that I think are concerning. For example, our rates of hospitalization for COVID in the state have stopped declining. And we've actually seen a tiny increase in the last couple of weeks. On the other hand, we have done great in Alabama at vaccinating our most vulnerable populations, and we'll talk about that. So there are many ways to look at what's happening in this pandemic, and I'll just give you my view. This is a really interesting website, and I put the address there for those of you who want to go in and really geek out on this. You can go in there and have it present visualizations of the data that are compiled by Johns Hopkins, which has been a fantastic place in terms of really tracking what's been going on. A lot of the graphics that you see on the news and the media are coming from there. But what they do in this particular graph is to show you relative to today, which is day 0. And can you see my arrow if I move it there like that? Fantastic. So this is today. And this is 392 days ago, which I know seems like about 1 million years ago to most of us who've been living through this. And what you're seeing here are numbers of confirmed COVID cases. So regardless of severity, by many, many different countries. And you can go in and focus on any of these countries, which is really pretty cool. But what I wanted to show you is what we have seen in the United States. And, I would say we had sort of a slow burn. We watched places like Italy and Spain, and a lot of places really start to increase. And we were kind of, I think, probably got a little bit complacent. And then really about a half a year ago, so in the fall, it's when things started to take off here. And we sort of have had these peaks and valleys. And these valleys have really happened because people got serious about social distancing and mask wear. There's really no, I think, scientific debate about this. Every time you look at these inflection points where the number of cases are going down, it's because people got serious and they got scared. Okay, so 84 days ago, when was that? That was around the beginning of the year, right? So we're in April right now, and this really represented the bad post-holiday surge. In this period of time, not only did people continue to react to this, but we started vaccinating, right? Which is a pretty remarkable thing. And then about almost 2 months ago, you start to see this plateau. And about a month ago, you start to see this little climb and then maybe a plateau and a little increase. So we could spend an entire week talking about what is really embedded here. But what I think is worrisome are a couple of things. The number of cases, I think, is stable. Maybe it's increasing. It's not decreasing in a way that makes us sleep better at night. The other thing is that while we have seen some decline in the death rate from COVID, we are still seeing way too many people die of COVID. There were in the United States over 700 people yesterday who reported being dead from COVID. Part of this may be just that we are catching up with the vaccine, but the other huge concern that keeps people like me up at night is that you have these variants coming out, and you've heard about these. These are types of the virus that have emerged to take advantage of an ability to be better at infecting people or to evading the immune response. And that's really, really scary to many of us. So let me go on to the next slide. The other point I want to make about this pandemic is it would be, I think, wrong to not touch on how bad the mortality has been. And the mortality, unfortunately, has been so profound that it has changed the life expectancy for adults living in the United States. And if you aren't aware of this, it's really pretty amazing. This is something that you see maybe once in a generation. We haven't seen anything like this since the influenza, Spanish flu pandemic. It's really remarkable. Not only that, but if you look at how it's affected different populations and you look at non-Hispanic Black men, this group has lost an average, of 3 years of life on average because of this pandemic. So people who are saying, well, most people did fine, young people did fine, that's true. But the toll is going to be written, I think, in the history books, and it's not going to look very good. So what else have we learned in the last 6 months? Just again, to orient you. As I said, it's true that most people don't get that sick. They get maybe a mild flu-like illness, maybe they get a mild pneumonia, and that's especially true if you're young. This is a great time to be young. Maybe it's always great to be young, but it's a particularly good time to get infected with COVID if you're young. Unfortunately, about 15% of people have really severe disease, and what we mean by that is that they essentially require help breathing. They just can't maintain adequate levels of oxygen in their lungs. The problem with this, as I'll show you in a moment, is that some of this is not directly related to the virus itself. So in the first week or so, first 10 days, the virus is actively multiplying in your body, and it's making you feel bad, it's making you sick, it's making you feel like you have the flu. After that, your body starts to essentially attack itself. So we call this sort of immunologic phase of the infection. And you've probably heard about this. People do okay the first week, the first 10 days of COVID, and then they really start to feel bad. And then they come to see us and they get admitted to the hospital. And sometimes they have to go on a ventilator. And that's what's been really, really challenging. It's very hard to treat once people get to that stage. Part of the other problem with this disease is it's really stealthy. So one thing, I'm not sure Dr. Kimberlin will mention this, but all of the things that we did this year pretty much eliminated influenza. So we saw almost no flu this year, which tells you how good what we did worked for your average respiratory virus. Even with all that we did, we still saw all this COVID. So this tells you that this virus is different than influenza. It's much more infectious, and it's much better. at establishing infection, which I think is very scary. The other thing is that most of the transmission of this virus comes from people who aren't aware that they have the infection. So as I'll show you in a later slide, you have a period before you start to feel sick where you are actively able to transmit the virus through sneezing, through touching your nose and touching someone else's hand, that sort of thing, through talking. So that is another scary thing that this virus has really taught us. Now, this is way too complicated for this group, but because it is a neuroscience cafe, I just wanted to point out to you that the research and the hypothesizing about what's going on with COVID at the level of the brain is just exploding. This is a fantastic article in the Journal of the American Medical Society Association of Psychiatry, just published under a month ago. It's really hard to keep track of the COVID literature because it's something comes out like every 2 hours. But it's a really interesting article that talks about how the brain is damaged by COVID. And it's almost freaky because it affects so many aspects of what should be a very immunologically protected area of your body. So it causes inflammation or agitation of the immune system in your brain. It causes things that make the blood vessels more likely to clot. It causes things that make you more likely to be more harmed when you don't get enough oxygen to the brain. So it's really a perfect storm for brain dysfunction. And that's probably one of the reasons that we are seeing so many post-COVID events that relate to mental function, psychologic function, and mental health. And this is a paper that literally just came out a few days ago that I wanted to highlight for you. They did a very nice study of a number of Swedish healthcare workers, 300 or so, who had actually gotten COVID and had antibody to prove that they had gotten it, and then about 1,000 who did not get COVID. And they looked at the presence of symptoms at various times after that determination was made. And I want to just take you through this list really quickly on the left. These are the most common moderate to severe long-term symptoms in people who had a history of COVID versus those who didn't. So seropositive means you had a history of COVID. Seronegative means you didn't. These are the durations of symptoms, 2, 4, or 8 months. So I would just have you look at a few things. At 8 months, 15% of people had any symptoms. That's a lot of people when you think about how many people had COVID. Even higher, 21. So 1 in 4 or 1 in 5 people had a symptom at 4 months. That's a long time when you think about the severity of these symptoms, which you can look at in this slide, and think about somebody trying to get back to work. We've seen people in our COVID clinic, young people, people with regular jobs who literally are 2 months out and can't really function either cognitively because of their brain function or because they are so fatigued, which is a really big factor at 3 months. So I guess one point I would make is that, any symptom at 2 months, 1 in 4 people, most places aren't going to give you time off from work at 2 months. So this may sound like, oh, most people were better by 8 months, but 2 months of disability, significant impairment, I think is very, very real. Let's just look down at sleeping disorder. That's a very common thing that we have seen, as well as concentration impairment. So not hugely common, but definitely something that we are seeing. And then if you look at the effects on people's work life, social life, and home life, these were significant in a mild number, or mildly significant in quite a few people. And this just basically reflects that slide. So the point of this is just to say that this is not your average flu. There's something about this virus that seems to impart relatively long-lasting concerns. You've read or heard about the brain fog. There are now estimates from another JAMA Psychiatry paper that brain fog may affect up to 1 in 6 people. And that's sort of a compendium of some of those symptoms that I mentioned. Now, Dr. Lutty and Susan asked us to talk a little bit about diagnostic tests, and we can come back to this if you have questions. I feel like this is less of an issue since we've moved to vaccines, but I think people may still have questions. You probably have heard a lot about the PCRs. The thing about PCR is that it's very, very good at detecting the virus if it's present. The challenge with it is that if it's not done correctly, you run the risk of having a false positive, meaning you get a positive result when you don't really have the virus. The other thing is that it doesn't tell you if the virus is alive or not. So it can't tell you if you are able to transmit the infection. But that's clearly what we've been using to diagnose the virus. And in general, it's been very, very good. People can remain PCR positive for several days and in some cases weeks after being infected, but it doesn't mean they're always infectious. We think that most people stop being infectious by about 9 days. So we'll come back to that if you have questions about it. The other thing I'll just mention at the bottom here are antigen tests. You may have seen some of those. They're generally cheaper. They're the point of care tests. So the ones that you literally swab your nose and you put in a you look for a color change with the swab. Those are actually generally good, but they're not all created equal. They're probably not as good as the PCRs. And so they've gotten better, but important to know what the quality of those tests are. Particularly if you're trying to rule out COVID. That's where these tests may not be as good as the PCRs. And then the last thing is serology. People ask, should I get a COVID antibody test? You know, I was sick last March. I'm pretty sure I had COVID. Could I get an antibody test to tell me if I've been infected? And the answer is maybe. Right now, we're not using these tests in that capacity because the commercially available tests are just not that good enough to tell us whether or not you really had COVID. The tests that they're using in the vaccine studies to make sure people got antibody after they got vaccinated are much more sophisticated and much more expensive. So I would say if somebody offers you a COVID antibody test, you should probably turn it down unless you know something I don't know. The last thing I was going to talk about was treatment. And you don't need to look at these fancy names, but I just want to show you these two buckets because remember, I talked about early on, you had this period in infection, maybe 7 to 9 days, where the virus is multiplying and make you feel really sick. That's when you want to use things that attack the virus. And probably the most famous one that you know about is remdesivir. That's the only one that is approved for treatment of the virus in this phase. Hydroxychloroquine does not work. Convalescent plasma probably does not work. Lots of good data. And really disappointing that we've only developed one antiviral that appears to work at this point, and it's an intravenous. So you have to get it through a vein. So we have no treatment that we can give you as a pill for this infection, which is a really, really big challenge. And then the other challenge is treating that later phase where your immune system starts to attack yourself. Steroids are the big thing that people use. Unfortunately, we see a lot of people getting steroids in this time, in the early phase. Everybody who comes to our COVID clinic has gotten steroids and antibiotic on the outpatient side, which is completely bad and wrong. Steroids are great, as are some other immunosuppressants later, but you really don't want to give steroids early in disease. And again, this is very complicated, but the main thing I want to point out is that in the early phase of the infection, you've got this phase where the virus is multiplying and you can use things like remdesivir down here, right? But then you go into this inflammatory phase where your body's attacking itself and you need to start using things like steroids. That's what dexamethasone is. So just to be aware that that's the case. I think this is the last thing I'll talk about, and it's a great way to transition to Dr. Kimberlin's talk. Monoclonal antibodies, you probably heard a lot about this, Regeneron, bamlanivimab, a whole bunch of things that can be used for prevention or treatment. And we may have time to talk about this later. We have an infusion clinic here at UAB where we've treated over 1,000 patients with this product or these products as a treatment. And I think they actually have made a huge difference. But just to make sure you know what they are, here's a little picture of the SARS-CoV-2 virus that causes COVID-19. It's got these little spike proteins, which you've probably heard about a lot. That's the protein that you want to make antibody against to fight the virus, because the virus attaches to your epithelial cells using these proteins. So if you could generate these blue things to actually bind onto the surface of the virus at that site, you could prevent binding. And that's exactly what active immunization with vaccines do. The alternative to active immunization is something called passive immunization, where you give people these antibodies, and that's exactly what monoclonal antibodies do. The challenge with this, there's two big challenges with these agents. One is that many of the early antibodies developed were single antibodies. So for example, bamlanivimab was a single antibody. The virus has already figured out how to get around it. So it's already evolved spike proteins that will not bind the stupid antibody. So basically it can infect you anyway. So we're now playing catch up, developing cocktails of antibodies that can bind the virus and prevent infection. The other challenge with this is that right now, most of the antibodies have to be given, as I mentioned, as an intravenous infusion. So in our infusion clinic, we bring people in who have COVID. They have to get the antibody over an hour, and then we have to watch them for an hour. So you can imagine if we had like several hundred people with COVID, that would not be feasible. So it's a great intervention if you can do it, but it's not a given. More recently, just very recently, there was a nice paper published that showed that subcutaneous injection, so just a little shot like you might give yourself insulin, can deliver these antibodies. And I think that's really encouraging, because you could use that for prevention as well as for treatment. So with that, I'm gonna stop. That's my Twitter handle if you wanna follow me on Twitter. And just a reminder to keep masking up until we know what's gonna happen with these variants. And I'm gonna turn it over to Dr. Kimberlin.
Jeanne, thank you very much. And thank you to the organizers of this. It's delightful to be with you this evening. I'm going to be shifting focus from the way that the disease occurs and how you manage it once it does occur to more of a discussion of how we can maybe prevent this in the first place. And really, I think that all of us see the vaccines and the development of vaccines as our best way through, arguably our only way through the pandemic. You know, I think right now we are stepping out into the early morning light. The sun is not fully up yet, but the complete darkness that we've been in for this past year is probably receding behind us. But it's a tricky time, and I think Dr. Marrazzo really alluded to that well. You know, it's not guaranteed that this is the straight line in front of us that we're going to walk. And it may be that those little upticks that you were beginning to see in some of her slides, the earlier slides, or are you know, telling us that we're not getting enough people vaccinated yet, and the virus is learning to make new variants, new forms of itself that perhaps are less suppressed by the immune response that is generated by a vaccine. So we're at kind of a tricky and a dangerous place. And then on top of that, we have some safety issues, very, very rare safety issues, but they're getting a lot of attention right now with the Johnson & Johnson vaccine. I'm going to talk about that more at the end and give you an update of what has been learned literally over the last 72 hours or so with regard to that. Now, I'm going to spend time on this slide and the following two, showing the 13 global vaccines that are either approved or authorized for use in some country in the world. And maybe we should take just a moment and talk about approval versus authorization. When, you know, normally a vaccine, a drug, a test, whatever it may be, receives the blessing of the Food and Drug Administration, it's a full approval by the Food and Drug Administration. That works great in normal times. In a pandemic kind of a situation where you've got to move fast, by definition, you have people that are dying, and you can't wait to go through the normal pace of doing things. In those situations, the Food and Drug Administration has the opportunity, the authority to authorize drugs or vaccines or diagnostic kits and tests for use. And it's the same kind of rigorous review, but it's not quite as broad a way to use these as a full approval would be, but it is a way that can happen pretty quickly. So the vaccines that we have in the United States, the three of them are authorized, not yet approved. I think one of them will be submitted for full approval within the next few weeks, and the other should shortly follow that. I'll show at the top, the very first line below the vaccine name, vaccine type, and so forth, is specifically the BioNTech Pfizer vaccine. It's BNT162b2. This is the first vaccine that received authorization. It's an mRNA vaccine, a messenger RNA vaccine. I'll show a slide on that in a minute, and we'll talk more about what the technology is there. It's approved in a number of different countries now, or authorized, I should say, and it was a multinational effort in putting it together. The row below that is the Moderna vaccine. This is the second one you've probably heard the most about. It also is a messenger RNA vaccine. It was developed by this company called Moderna with significant involvement from BARDA and NIAID. Those are two portions of the federal government that provided a lot of funding for it and also a lot of scientific expertise for it. So it's a fully US developed vaccine. And it goes by the nomenclature of mRNA-1273. The third one on this list is the AstraZeneca vaccine. This one is not authorized for use in the United States at this time. They've not submitted the paperwork or the documentation for consideration of authorization. So it's nothing about the vaccine in particular. It just hadn't been submitted to the Food and Drug Administration for consideration. Unlike the mRNA vaccines, this one is called a non-replicating adenovirus vector vaccine. And I'll talk a little bit more about what that is. It's a different way to get the code that tells a cell to make the spike protein of the virus, getting it into the cell to have that all start up in the first place. This was developed in the United Kingdom between AstraZeneca and Oxford University. The fourth on the list is Sputnik 5. This was, I think, the first one to actually receive a type of authorization in the world. It's a Russian vaccine. They actually authorized or approved it before they'd completed the studies on it. So there's a lot of question marks about whether this really works very well. It also is an adenovirus vector vaccine. And then the final one on this is the J&J vaccine, or Janssen or Janssen vaccine. This is the one that you've been hearing about over the last few days. It also is a non-replicating adenovirus vector vaccine, and it was developed in the Netherlands and the United States. On the next slide, we're going to see some additional vaccines. CoronaVac is a Chinese vaccine. This is receiving a lot of attention around the world. The Chinese have done a very good job of using vaccines as a diplomatic way to kind of spread influence, and a lot of countries have taken them up on it because they've not had access to vaccines that have been developed in the West. It's an inactivated vaccine, so essentially they take the virus and just sort of kill it. And that's what they inject into a person, and it's supposed to generate an immune response. I believe that this was the vaccine that it was reported recently, a member of the Politburo in China, I think, or maybe someone with the China CDC, indicated that they did not think it was as effective a vaccine as some of the Western vaccines that we have available here. There are other Chinese and Russian vaccines and an Indian vaccine that are listed on this slide, different types of vaccine technology. And then on the next slide summarizes the remaining 3 of the 13 that are approved or authorized somewhere in the world. Again, China, Russia, and China and Uzbekistan combined. Now on this slide, we have a schematic of some of how these vaccines work. So in the upper left corner and the lower right corner of this slide are sort of schematics of what a cell is, a human cell is. or person is, in terms of how the immune response would be. And they're mirror images of one another. And the reason we had to have two of these on this slide is because there's a lot of different vaccine products that are represented here, and just couldn't cluster them all onto a single type of a graphic. If you look at the light blue in the middle, that's the mRNA vaccine. That's the Pfizer vaccine and the Moderna vaccine. And what they do there is they take the little code, like a computer code, that tells the cell of a person receiving the vaccine to make the spike protein of the coronavirus, the SARS-CoV-2 virus. And it basically puts it in a little fat bubble, a little lipid bubble. And then it injects a very tiny amount, micrograms, into the muscle of a person's arm. The little fat bubble gets the mRNA into the cell, the person's muscle cell in their arm. The muscle cell then does what it's supposed to do and makes copies of the spike protein that it puts onto the outside of the cell. And then the person's immune system can see that spike protein and develop an immune response to it, so that the next time the person is exposed to the real virus, their immune system is ready to pulverize the virus before it can actually infect them and cause them to be sick. That's essentially how all vaccines work. The particular nuances of the Pfizer and the Moderna vaccine is that it's that mRNA in a fat bubble that has made it rather unique. These are the first times that these types of vaccines, this vaccine platform, has been used. And then in the kind of lower 2/3 down left side of the screen, there is a purple oval-shaped shape that has a viral vector vaccine. This is what the AstraZeneca vaccine is and the Johnson & Johnson vaccine is. They take a harmless adenovirus, that's like a virus that causes the common cold in a person. In the case of AstraZeneca, it's a chimp adenovirus. In the case of Johnson & Johnson, it's a human adenovirus. And they take out one of the genes that is required for the adenovirus to replicate. That's why it's called non-replicative. It can't reproduce itself, but it can serve like a car to carry a piece of the genetic information, the mRNA in this case, the same kind of mRNA that we talked about with the Pfizer and Moderna. But instead of being in a fat bubble, it's in this adenovirus vector. They put it in there, they inject it, the adenovirus goes into the cell, the mRNA comes out of the adenovirus vector, copies of it are made, the spike protein is made, it goes to the cell surface, and the person's immune system sees it and begins to mount an immune response. So these are the ways in which these two different vaccines can work, two different vaccine platforms can work. The key thing is, in each case, you're getting messenger RNA for the spike protein into a muscle cell, and then the cell is making protein, putting it on the surface, and the immune response follows. On the next slide, we have a summary of the Pfizer vaccine, the Moderna vaccine, and the Johnson & Johnson vaccine in terms of pain, fatigue, headache. You can read down, and then in the lower portions of the slide, efficacy, how well they work. So you can see that especially the Pfizer and Moderna, these are remarkably similar vaccines in terms of how they were used. In the Pfizer vaccine's case, it was like almost 45,000 people that were in the study. In the Moderna vaccine case, it was 30,000 people that were in the study. But they were done in different populations at different times, overlapping times, but not exactly in the same group. And yet you see the very, very similar information. Both of them have a little bit more reactogenicity. They have a few more side effects in younger people compared with older people. They defined younger in different ways, 16 to 55 years for Pfizer, 18 to 64 years for Moderna. And you can kind of see as you work your way down this slide, about 80% or so will have pain if you're younger, and around 70% or so will have pain if you're older. Fatigue and maybe a third to a half, headache in a quarter to about 40% or so, muscle pain in about 15 to 20% of people, joint pains in about 10%, chills in 5 to 15% for Pfizer, a little bit more likely to have chills with Moderna. I think it's been our clinical experience as well, not just in the studies, but in seeing how these actually behave in people when they're getting the vaccine. And then either single digits or low double digits for fever as well. The Johnson & Johnson vaccine on the right-hand column has 60%, 45%, 40% in terms of pain, fatigue, headache, muscle pain, and so forth. Now, the Pfizer and Moderna vaccines are given as two different vaccines. If we could back up real quick for a second. So when you look at how well they work, and these are the lower two rows on this particular slide. If you look at how well these work, the protection against all infection is about 95% after you get the second dose, 7 days or more after you get the second dose. That's amazing. That is absolutely phenomenal. I would have been happy at the beginning of all of this with something that worked 50% of the time. These work 95% of the time in terms of protecting against all infection, and they have 100% protection against severe infection. Now, after one dose of either Pfizer or Moderna, you're already getting benefit. So between the first and second dose of Pfizer, which is a 21-day interval, between the first and second dose of Moderna, which is a 28-day interval, somewhere around 80 to 90% of protection against all infection is occurring, and you're even getting protection against severe disease. And for Johnson & Johnson, done at a totally different time in totally different countries, US included, but at a time when these variants were already circulating, you still have 85% protection against severe disease. Phenomenal outcome. So all three of these vaccines are extremely good vaccines, and the best vaccine for you is the one you can get in your arm at that particular time. Next slide. This is going to show us for the Pfizer vaccine what the benefit is over time. So let me orient you to this, because you're going to see several copies or versions of this kind of a graph. On the x-axis is time, and it's in this case time after dose number 1. Since this is the Pfizer vaccine, you can see for the 21 mark down near the bottom, that's when they got their second dose. On the y-axis is the cumulative increase in numbers of cases. So you want to be flat down along the x-axis. You don't want to have a bunch of cases. And indeed, that's what the people getting in the blue line, getting the vaccine, what you really see, whereas you see just a steady increase in cases among those people getting placebo or sugar pill or sugar injection kind of thing for those getting the placebo. But interestingly, around day 10 is where these lines diverge, where the red is going up and the blue flattens out. And that's even before the second dose. So if we go to the next slide, we're going to see the same sort of thing for Moderna. Moderna's interval is 28 days. You see a dose 1, a dose 2, time on the x-axis, cumulative cases on the y-axis. The separation here occurs somewhere a little bit beyond day 10. And is well underway by day 20 or day 21, with continued protection among those that were vaccinated versus continued risk of acquiring the infection among those getting placebo. Next slide. Let's look at the same sort of thing for the J&J vaccine. Now, I'm going to show you a couple of things. This is for moderate to severe COVID globally. This is a single dose vaccine. You only get one injection with it. And so you begin to see it about 14 days after you get the vaccine, this separation where you have a lot less likelihood of getting infected if you got the active vaccine, and a lot more likelihood of getting infected if you got placebo. And then the following slide should show the severe critical definition of COVID. And that protection occurs even 7 days after getting the single dose. So these are all great vaccines. I guess if we could go to the next slide, I'll just talk briefly about, this is a picture of Children's Hospital. I love that picture. If we could talk a little bit about what you've been hearing about some of the clotting side effects that are being reported with the Johnson & Johnson vaccine, and previously had been reported with the AstraZeneca vaccine. Again, in the United States, we don't have the AstraZeneca vaccine. So what was being recognized as happening in Europe and in the United Kingdom gave us a chance to begin watching very carefully for it in a similar but not identical vaccine, the Johnson & Johnson vaccine that relatively recently, it was the third and the most recently authorized vaccine in the United States. It was reported on Monday that we had 6 cases in the United States of what's called cerebral venous sinus thrombosis, which basically is there you have some big veins in your head that drain blood away from your brain, and clots can form in those large veins, and that's what was happening. The thrombosis means clot. And interestingly, it was happening at a time when the cells in your blood that cause clotting, called platelets, were actually low. So you had low platelets, and yet you still had clots in some of these large veins. I will say, though, it's in 6 people out of 7 million or so doses that were given. It was in women. They were between 20 and 50 years of age. So if you look at the numbers of doses that were administered to women in those age ranges, it was probably about 1.5 million doses delivered. So 6 out of 1.5 million. And if you looked at whether that was going to happen anyway, just every single day, something's going to happen to some people in the United States or around the world, it would happen about 1 out of 100,000 cases or people at any given day would have one of these clots form. If you do the mathematics on it, the very preliminary information is that there is an increased risk in people who are getting the Johnson & Johnson vaccine. And the risk is somewhere between 1 and 3 weeks after getting the vaccine. However, the risk, probably is less than getting struck by lightning twice. So, you got to think about what is it more risky to not be vaccinated with this and potentially, acquire COVID and die from COVID, or is it riskier to be vaccinated? And right now, the Centers for Disease Control Advisory Committee on Immunization Practices, which is an advisory group to the CDC, had an emergency meeting yesterday. I'm a liaison to that group from the American Academy of Pediatrics. It was a fascinating conversation, and they asked for more information. They basically said, let's come back in a week and let's see what we know at that particular time. This vaccine is paused right now in the United States. That pause effectively is maintained until the ACIP comes back together in a week or 10 days and looks at the new data and makes a determination as to whether everybody should be recommended to receive the J&J vaccine if you're 18 or over, or whether it should be restricted by gender, or whether it should be restricted by age, or whether it should not be recommended at all. I don't think that's going to be where we end up, but we don't know for sure right now. It's causing problems around the world because many countries in the world don't have access to anything except J&J or AstraZeneca. And so what we do in the West is as we think about our acceptable risk can be a totally different calculus for someone in the developing world. And so there's all sorts of ethical issues here from every single angle that you can think of. And that's why I think the ACIP wanted to take things slowly. I'm going to stop with that and turn it over to Jeanne and see if she has additional comments on this. And then I hope we have time for some questions. And I thank you for your time and your attention.
None for me, David. That was fantastic. Thanks for your insights. And also thanks for your service on the ACIP. I know you have been meeting like on weekends and at the drop of a hat to deal with all this like deluge of data. So really, really grateful for your service there. So I will turn it back to Dr. Lati and anyone else who wants to comment or ask questions.
Yes, well, thank you very much. This was incredibly informative. I mean, I've heard a lot, and I've heard you, Jeanne, at UAB speaking about it a lot, and I still learn a lot. We're going to open the discussion to everybody, but my first comment would be, the impact of the Johnson & Johnson, what's happening right now. It's really incredibly disturbing because, my fear is that some people were reluctant not to get vaccinated, are going to take, this as a really bad news. And also, I was thinking, I'm a psychiatrist, and people with severe mental illness have been shown to be at increased risk to develop COVID. And, I was hoping that, we would be able to use the Janssen vaccine to vaccinate, patients while they were in the hospital, because it's very difficult to, to do that once they are returning the world. So anyway, Dr. Kimberlin, do you would like to comment on this?
Yeah, I mean, you're making excellent points. This has all happened just literally in the last 72 hours. So I don't think that the Johnson & Johnson vaccine is off the table. It is right now. It's paused right now. But it very well might become, again, an incredibly useful vaccine, not only in the United States for situations like what you described, or people that just prefer to get one shot instead of two, but around the world. I will say this, though. I hear what you're saying about vaccine hesitancy and about some confusion around vaccines. This undoubtedly, adds to some of that confusion. But here's what I think is a really positive aspect of this. Our safety systems in the United States are so good that out of 7 million doses, we found 6 people in a matter of days or a handful of weeks. And we're able to understand to a pretty high level of benefit what is happening in those 6 people. I think now we'll learn a little bit more, and we'll learn whether additional people have been affected by this. But the issue now isn't so much is it out there, but rather what's the risk versus the benefit, and that's gonna require a lot of reflection and discussion and debate. I think we should all celebrate, though, just how good our safety systems are. That's a really positive aspect.
We have a question. Can you unmute yourself, Caroline? Susan, can you unmute? Caroline.
Okay.
Here we go.
Yes, I'm Caroline. This is Robert, my husband. And just today we heard from a friend that her son-in-law was due to have his second vaccination next week. Well, Monday of this week, he started feeling bad. And so his doctor said, go in and get a COVID test. So he went in today to get his COVID test. He tested positive. He was on his way home on 280. He blacked out. He wrecked. When 911 came, now he's in the emergency room with not only COVID, but with lower back pain. I'd like your...
Well, the question is, did he had the COVID previous to the first shot and they didn't know it, or did the first shot give him COVID?
Jeanne, you want to?
Sure, I can start. So you can't get, it's very important to know you can't get COVID from these vaccines. None of the vaccines are live virus. We do sometimes give live viruses as vaccines, but even when we do that, they are damaged so that they can't go on to cause the infection almost 99.9% of the time. So he wouldn't have gotten COVID from the vaccine. What's much more likely is that he got that first shot. And remember, as Dr. Kimberlin showed, 2 doses are much more effective than a single dose. So a single dose is good. It's in the 70s. That's pretty amazing, actually. But 2 doses are around 95%. So odds are pretty good. He was one of those unlucky, one in 4 people who just happened to get exposed to COVID after that first shot and got infected. My suspicion about why he didn't feel good today is he has a bad case COVID. And unfortunately, that's, what we see. So hopefully he'll get better. He can get his second shot. What the CDC recommends, and David can probably talk about this more detail, is that 2 weeks after your symptoms resolve, you can get that second shot if he wants to do that.
Well, I'm sure he will.
David, any
Thank you.
No, the only additional thing I would add is that it's quite possible. Of course, you can't ever turn back the clock in not giving the vaccine to begin with. But my suspicion is that he would have had a more severe case of COVID if he hadn't gotten that first dose of the vaccine.
Yep.
So it obviously, that from what you're telling us, didn't protect him fully, but it still could have protected him somewhat. And I as well hope he gets better. That sounds like a terrible day.
Yeah, I hope he's okay.
Thank you.
Okay, I have a question in the chat. What are your thoughts on testing in school? Should we be providing surveillance testing on a weekly basis? So there's 2 questions.
I think, and the CDC and the AAP and a lot of political leaders have really come around to recognize that children should be in school. Think how much we've learned, from a year ago when the shutdown was first occurring versus what we know now. We do have cases in schools. But we have very few situations where those cases are driving things. Schools exist within a community. So if you have the virus in the community, you're going to have the virus come into the schools. But unlike flu, where, with flu, it kind of starts in the schools and then spreads out into the community because children are better at kind of spreading flu, whereas adults are better at spreading COVID. So point number one, children, in my judgment, should be in school. And I know it's a lot easier to say that than it is to actually open the schools necessarily, but more and more going back to in-person learning, we know that remote learning is just not as good. And so there's risks for not being in school. So then the question is, what do you do to keep them maximally safe in school? And I think part of it is to protect the teachers. The teachers should be getting vaccinated. All of us should be getting vaccinated. That is our way through all of this. And then there also, I don't think testing in school is necessarily the best way to utilize those resources. But I will say this, that studies that have looked at more frequent testing versus less frequent testing have found benefit of more frequent testing. So whether you're doing routine screening in schools or not, and I've not heard that as a real method right now in most schools anyway. You should have a very low threshold to test, and you should quarantine and respond accordingly, as we've all gotten so used to over these last 12 months. Jeanne, what are your thoughts? You're on mute.
Yes, trying to be muted. I would agree. I think before implementing a testing program, you got to ask yourself, why are you doing it? And as you start to get positives, what are you going to do about that? And how is that going to help you in the long run? So for example, we had been doing routine surveillance testing in our healthcare workers, as well as in our college students. And we recently sort of stopped doing that because, as Dr. Kimberlin said, the numbers have been coming down, and it's not a good investment. It's a lot of money, and it's a lot of time. So there's a point where you got to sort of figure out, is there so much disease in the community that it's going to be helpful for you to do that? If you could do that and isolate that outbreak and then do contact tracing and put everybody in quarantine, and you could shut down these little blips of outbreaks, that would be fantastic. We are not there yet, both in terms of our capacity and where things are going. So I think it's an interesting idea, but I think we got to sort of work through some of the issues that David mentioned before we go there.
And a very quick follow-up. Right now, the Pfizer vaccine is authorized for 16 and 17-year-olds. It's the one that dips down into the pediatric age range. And they've submitted their request for authorization for 12 through 15-year-olds. And word is that Moderna is going to come in and ask for authorization for 12 through 17-year-olds. So I think over the next month or two, we're going to start vaccinating teenagers like we're vaccinating, the adults in the world or in the country. And then I would think maybe by the fall, if things go well, we might be able to start dropping those vaccination authorization ages down into the more elementary school age range. I don't know if it'll happen before school starts or not, but the vaccine is coming for children as well.
This is really excellent news. Thank you. I have another question in the chat. After having COVID, how long does one have antibodies that are effective against getting the virus again?
I can just start with that. I know David's been very close to that too because of the ACIP work, but it's a good question because just literally this week, there was a letter that came out on the extent of antibody to the Moderna vaccine 6 months after infection. And it's basically the same as it was when you got the second dose of vaccine. So really excellent data to say in the vast majority of people at 6 months, superb levels of antibody. There are other data in smaller groups. I mean, the reason that's important because it was a very large group of people that got Moderna, and it's sort of more of a real world evidence, I would say. There's, I would say, some limited data in smaller groups and also some theoretical stuff from the lab to suggest that it's going to last at least 8 months, if not a year. So I think that the main threat to durability is the variants. So if we can get ahead of the variants, we can get this under control before the variants emerge that are going to beat the vaccines, we're in an arms race against the virus evolving against the vaccines. So the good news is that the antibodies you make to the vaccines that are directed at the variants we knew about are good. It's just a question of whether it gets around that in the next several months.
Thank you, Jeanne. Another question: in the long run, what sorts of restrictions are there going to be on private citizens traveling to other countries? When will this open up, do you think? And what is your expectation about vaccine passport, proof of testing? This is a hot topic, right?
David, you want to start on that?
Okay, we're still recording on this. All right. Boy, those are for international travel. I don't know. I think that, I do think that we all recognize we're in one world here, and the fact that we're talking about UK variants and South African variants and Brazilian variants, shows that we should care about what's happening in other parts of the world. Now, we need to care about what's happening here in the United States as well, but until this is really kind of being controlled better than it is right now globally, we're all at risk. So how that impacts international travel, I don't know. I would not be booking an international flight for in the near future. I'll put it that way. Vaccine passports. I don't think that,
if you are at UAB, you will have a UAB passport, a vaccine passport.
I love that.
Yeah. My guess is that it will be market driven. That when airlines, for instance, if they were to say this flight is all people who've been vaccinated and this flight isn't, I think that's going to drive people to want to be on the flight that is, and that means get a vaccine. I think if restaurants are able to open up at fuller, larger capacity because they only let people in who've been vaccinated, that's going to drive a bottom line business decision to maybe start requiring vaccination proof, unless you're in Texas and Florida, of having received the vaccine. I personally don't think the government can do it. I think it's kind of self-evident about people's views on the government, and they don't want to be told what to do. I mean, they couldn't even wear a mask. So I can't see that that's going to be a real issue for us. But I think that the market will take care of that. And my guess, I'm only guessing, is that there will be more and more places that we all would like to go that will say, we'll let you in, but you got to show us that you've been vaccinated.
Well, that's what's happening in Israel, right? They have the passport, and that it looks like it's really is driving people to get vaccinated. So that could work. So we have another question. What is the data on safety and efficacy for pregnant women and their babies when born?
For David, I think.
Yeah, pregnant women were not included in the studies. So we have an increasing, but there were some that got pregnant after they enrolled in the study. And we have an increasing safety database that I mentioned, that incredible safety system that the CDC and the FDA have. It's overlapping systems. So we have a lot of information and an ever increasing amount of information about use of the vaccines in pregnant women or breastfeeding women. There is no problem at all from using these vaccines in pregnant women. We are not seeing any safety signals at all. In fact, we're seeing benefit because we're finding that antibody is in breast milk, which protects the breastfeeding baby. And we're finding that antibodies cross over to protect the fetus so that when the baby's born, they're tanked up, if you will, with antibody that can protect them against COVID. Now I don't want to overstate that because that sounds like it's a definite protection, but the evidence as it's coming to us looks very encouraging in that regard, and we're not seeing safety problems. On the other hand, if a pregnant woman does not get vaccinated and she gets COVID, she's at increased risk of very severe disease and of having a premature baby. And then there are lifelong consequences of prematurity sometimes for those babies that are born premature. So we know the risk of natural disease, and we have no evidence of anything but good benefits from the vaccine. And the recommendations from ACOG, which is the OBGYN society, from IDSA, from the Pediatric Infectious Disease Society, and from the American Academy of Pediatrics, is that pregnant women should not be discriminated against by withholding the vaccine. They should be offered the vaccine.
So thank you, David. Another question, do you anticipate annual vaccination for COVID similar to the flu vaccine?
Jeannie, what do you think?
Yeah, I think it all depends on the variants. So if none of the variants take hold, and all we're dealing with is the original quote unquote Wuhan strain, and the subsequent variants, which did not appear to be problematic with this current generation of vaccines, then I don't think so. Unless we're faced with this issue of how long antibody to coronavirus in general lasts. So remember, there's a reason that we get the common cold every year, right? We get that, and David is much more, he can comment on this. I mean, part of it is because immunity to coronaviruses, there actually aren't that many of them, but immunity to them does not, is at least with natural infection, meaning the one you get from being out and about in the wintertime, doesn't seem to last that long. So I think the questions are just legion. Number one, assume you got no variants that you got to worry about. Then, is vaccine-induced immunity to the coronaviruses going to be better than our natural immunity? Then two, if the variants continue to emerge, then I'm sure we're talking about booster shots. So David, what do you think? That's a tough question.
Yeah, no, I think I would agree with that. My guess is we will have booster shots, and I would say that's fine. I mean, that's not a failure. What we really need right now is for everybody to get their first shot, or their first and second shot, I guess, if you're getting Pfizer and Moderna, and that'll be the best way to drive down the amount of virus in our communities around the country. And throughout the world. And then if we find we need a booster shot every year or 2 years, that's fine. We would have had a successful vaccination program.
And I would like at this point to underline the technology for these vaccines, because if they happen to be new variants, those booster shots can be designed much quicker than old-fashioned vaccines, correct?
That's exactly right. These mRNA vaccines, I touched a little bit on the technology of it. This is Star Trek kind of stuff. This is amazing, and it likely, we got to get through the pandemic first, but it likely is going to change vaccine development in ways we cannot even think of right now, because it's so easy to do a plug and play. Basically you just take the mRNA you want, you put it in the little fat bubble, and you're ready to go. And so it really is amazing technology. I agree with you.
Okay, I have a question that was previously asked, so I think we have answered that one. And then we have a comment, a little bit of sarcastic comment from Tim Gunn, making. Okay, I have this here a question from Trudy Loop. Trudy, did you want to ask the question? You have a long, can you unmute yourself and ask the question? Because you are reporting some sorry.
Yes, my first question was, are there studies that have shown that if you have antibodies before you get the vaccination, that you have a stronger reaction to the to the vaccine? That's been some speculation among people. I just wondered if there's data to support that. My second question is more of a personal level, maybe help with public messaging on people who want to go visit someone who's been on a ventilator for a long time, who needs visitors, who may not recognize you when you're there. But I haven't seen anything. Like, I tried to Google before I went to see, what to expect or what to try to do when you visit someone. I know that's not a vaccine question, but I imagine it's something that the speakers have experience with.
Maybe I can just address that first, and then I'll turn it over to David about your vaccine antibody question. So I just literally came off the inpatient hospital service. I was on the last half of March, and people talk about COVID like it's going away, but we have about the same number of people with post-COVID, meaning they have been in the hospital and they develop complications of COVID, that we've had pretty much since the start. And we have about 50 patients who are not infectious. They've gotten quote unquote over COVID, but they're there because they're still intubated. They're there because they are requiring other high level care, or they've gotten infections in the hospital that, or they've had complications like kidney failure or heart failure. So I feel like we've kind of not talked about those things enough. And for families, especially, and friends like you who are trying to support those patients, there's no playbook. I mean, it's like how, what do you even, we're not, there isn't a way to Google it. I think it's really, really, really frustrating. And you also alluded to the fact that he doesn't recognize you. So he probably has had some neurologic dysfunction from all of that illness. So I think at that point, I mean, I'm not an expert, and I think maybe there are some psychiatrists on the call who could probably be more helpful. But I think at that point, you just have to treat it like anybody with a chronic, devastating illness, right? Almost like somebody who had a stroke or somebody who has been in the hospital with a long-term illness, and just say, you're just going to try to show up and be consistent and not be afraid, because you're not going to get infected from this person. And it's really more important to show up for them. There's lots of interesting data to show that even when people seem really out of it in those situations, they remember, they've heard things. You want to be very careful about what you say. Some really interesting data about that. Again, not my area. So I would just encourage you to try to get people to, be consistent and really try to be there for your friend, because that's a very tough place to be in.
Yeah. One thing I've encouraged is cards. So we're starting this week with cards, and then we'll know a little more from the family about how to schedule the visits. But this person does recognize other people. I think on that day when I went, there just wasn't any recognition, or there was a good deal of depression. So I don't know.
Yeah.
Thank you.
Sure.
Thank you.
And for the first question, a couple of things. There were some people in the studies, the very large studies, they didn't exclude you based on whether you had COVID before or not. And they, at the very beginning, before they give a shot of the vaccine, they would draw blood. So they were able to go back in time after they gave the vaccine, the first and second dose. They could go back and look at that very first blood draw to see if that antibody was there. In other words, if the person had blood evidence of having had COVID in the past. And for those that had COVID before, there were not increased adverse reactions or side effects from the vaccines. So first and foremost, it's safe. And then in terms of the response, there are some studies that are beginning to come out that would suggest that that the people who previously had COVID and then get a first dose of the vaccine have a really nice increase in the antibody titers, because it's kind of like they're kind of like getting a second dose of someone getting a 2-dose vaccine who'd never had COVID before. First dose is kind of that booster for them, if you will. They still should get 2 doses. We're not at a point where we can fine tune things so much. We just got to get more doses into more people's arms, and to get ahead of the variants. But it's safe, and if anything, they're going to have even a more robust kind of a response.
Mm-hmm. Okay. So no indication that having more of a reaction meant that you had COVID before.
No, not that I follow you now. Not that I'm aware of. These mRNA vaccines. I mean, you saw that table. they are what we call reactogenic. I mean, there are reactions to it, but you want that because that means they're also immunogenic, which means they're turning on your immune system exactly as you want it to happen. So honestly, when people say, look, I had chills after my second dose, say good, that means, you got a good take. It's a positive kind of development.
Mhm. Okay, thank you.
Okay, we're getting to the end of this NeuroCafe, but I would like to ask maybe a last question is about what can we do to get people to get vaccinated? It looks like there's really two types of people, those who cannot wait to get the vaccine, and on the other hand, there's people who are so reluctant. What can we do?
This is where you all are much more influential than Jeannie or me. Tell all of your family, all of your friends to get the vaccine. And I mean, don't turn into a stalker or something, but say it loud, say it frequent, say it definitively. Get the vaccines yourself. Be a model in your community for it. And people will listen to you. Not everybody. We can't have everyone listening to us and doing exactly what we believe they need to do, but they will listen much more to you than they might to a talking head on TV or onto a recorded kind of Zoom session or something like that. They will listen to you. So don't underestimate your power. You have power here to help bring this to a close for you, for the people you care about, and for your entire community.
Great. Well, thank you. That's an excellent point. Are there other questions? This is a fabulous opportunity to ask questions. So, great. Okay. Well, thank you very much, Dr. Marrazzo and Dr. Kimberlin, for this really very interesting discussion and talks. So thank you, everybody, for coming to the Neuroscience Cafe. And then get yourself vaccinated and then engage other people to get vaccinated. So we have an important task to do. So thank you again.
Thank you. Stay safe, everybody. Thanks for having us.
Have a great